I'm Associate Professor Lionel Reyftmann, a French-Australian gynaecologist in Wollongong in the Illawarra in Australia. Today, the subject that we're going to discuss is Polycystic Ovarian Syndrome, also known as PCOS or PCOS. PCOS is a very common encounter in my daily practice, and it's estimated that approximately 1 woman out of 10 suffers from this condition. I have found over the years that there is a lot of confusion. I have a lot of people who come to see me thinking that they have cysts in the ovaries that can be dangerous, that they can rupture, that they can create pain. And in fact, there is a big misconception. As a matter of fact, the scientific committees that are working on PCOS have decided that we should change the name to create less confusion. So what is it? Well, in a nutshell, Polycystic Ovarian Syndrome is a condition where inside the ovary, for a woman, there are basically too many eggs, too many follicles. I'm not sure why it's called the polycystic syndrome. It should have been called the polyegg syndrome or the polyfollicle syndrome. But for a lot of women, the PCOS reflects the fact that they have an abundant and kind of excessive ovarian reserve. All those little follicles, all those little eggs, when you look at them on the ultrasound, they look like little bubbles. And I think that this is where the confusion is coming from. When you look at the scan, it looks like little holes, like in Swiss cheese, and people for a long time believed that it was in fact a problem of cyst. But if you look at these very carefully, they are not cysts, they are just follicles and eggs. Now the problem is that those follicles, to become the mature follicle that releases and produces an egg, they have to produce an intermediate fuel, a compound that's very important for their development, that is a male hormone. It's called an androgen, or also sometimes testosterone. So if you have too many follicles, you have inside the ovary an excess of production of androgens and testosterone. And that can translate in physical symptoms that women have, mainly the presence of hair, dark hair generally, in regions that you would otherwise find in men. The upper lip, the chin, the sideburns, the chest, around the nipples, or towards the belly button. The second thing is that they can suffer from hair loss, or sometimes a problem with their skin, oily skin, pimples. They can have problems of hormonal acne. Eventually, because of all those follicles that they have and the excess of hormone and testosterone, that quite commonly results in a delay or a blockage of the menstrual cycle, and they stop having their periods or have very spaced irregular cycles. To say that someone has polycystic ovarian syndrome, it takes 3 things: the excess of male hormone, the irregular cycle, and the presence of multiple little bubbles in the ultrasound. You need to have at least 20 follicles in each ovary. So when people come to see me, we take a full history, we analyze their physical characteristics, we do some blood tests, ultrasound, and we offer a plan of treatment. And the treatment, if the problem is just a hormonal imbalance, irregular cycle, could be a hormonal simple treatment like the contraceptive pill. If someone has polycystic ovarian syndrome and is insulin resistant, they have difficulties to metabolize the insulin and they have a predisposition for elevated sugar and diabetes, we make them lose weight. Nutrition advice, seeing a dietitian, exercising regularly. We recommend generally at least 30 minutes of brisk exercise every day. We recommend a Mediterranean type of diet with fruit, veggies, fibers, lean meat. That's generally able to control the problem, but we also use medications. The most interesting one is metformin. On the social media at the moment there is a lot of buzz about something that's called the inositol, and the inositol has been studied. There are some interesting leads of research, but it's not validated for the moment. So the cornerstone of the treatment is the metformin. With that medication and the lifestyle changes, people can lose weight, control the insulin resistance, and have a better ovulation. The people who come to see me, they very often come with problems of infertility. And if they don't become pregnant and they have PCOS, we treat them with tablets that make them ovulate. They are like fertility boosters. The best known medication is called letrozole. The letrozole is a tablet that you take at the beginning of the month that make you ovulate. It's an effective treatment, but if it doesn't work for everyone, I would say that approximately 30% or 40% of my patients may resist to that treatment. We give them injections. The injections of gonadotropins are a powerful treatment that can make you ovulate, and they are so powerful that in some cases they can create a side effect of those treatments, which is a multiple pregnancy, twins and triplets. So we are very careful with the use of those drugs. It takes a lot of expertise and skill to give a safe treatment. And in some cases, when it doesn't work, we do a surgery. It's an operation where we perforate the ovary, creating little holes. It's called an ovarian drilling. And in Australia, I'm one or maybe the only practitioner who has used a technique called the fertiloscopy, which is a minimally invasive operation that we do through the vagina to access the ovary and create this ovarian drilling. At the end of the road, for some women, when everything has been tried and they still want to become pregnant and they are unsuccessful, we use IVF and fertility assistance. PCOS, in conclusion, a very common condition that affects 10% of the population. It can be managed with lifestyle measures and medication working on the insulin resistance, but in some cases, if you become pregnant, you're going to need some help, and we can use tablets, injections, IVF, or surgery.